Good mid-morning. I hope everyone got some caffeine and a stretch, got out and enjoyed the sun just for a second. It's a privilege to be back in Sedona. It's a wonderful conference, and thanks for being part of it. We'll work on the order. It's always easier if I go before Amy, just because she's so hard to follow. So no disclosures other than I am an interventional cardiologist. The learning objectives, so what I'd like for you when we finish this 25-minute talk is I'd like you to be able to explain the impact of PCI clinical setting on dual antiplatelet therapy and how you choose what, when, how long, how to interrupt. I'd like you to be able to choose the dose and timing of an antiplatelet when you're switching drugs, because this comes up a lot. People want to go from one to the other, or they get the bill for their ticagrelor. And finally, I'd like you to make an informed recommendation regarding the timing of interruption and discontinuation of dual antiplatelet therapy after PCI. And we're going to try and get there by talking first about the setting of DAPT, and really that PCI and stable ischemic heart disease is not the same as when it's done in acute coronary syndrome or STEMI, and it's very important to look at what was going on with the patient when the stent was placed. I'll give you some examples of that. We'll talk about DAPT switching, how to do it. Then we'll go on to DAPT interruption, and in there talk about bare metal stents. Do they still have a role? Just briefly with respect to DAPT. And talk briefly about bridging, specifically with cangrelor, because this keeps coming up as, well, could we bridge them? And should we? So, and finally, we'll talk about when to stop DAPT. So we have patients that come back to clinic and, you know, it was 3 years ago that I had my PCI. Can I finally stop my clopidogrel? And how do we make that decision? So warm up your buttons. There's a number of interactive questions here, so I'd like this to be an interactive session. So reach out for your answer questions here. We'll start with a 70-year-old woman who presented to the hospital with new onset angina. She had a positive biomarker. Coronary angiography reveals single vessel coronary artery disease with severe stenosis in the proximal LAD. Stenosis is treated with a single drug-eluting stent, a good angiographic result. So how long should this patient be treated with dual antiplatelet therapy? 3 months, 6 months, 12 months, 18 months, 30 months? It's the kind of questions that we get all the time in cardiology. Out of 182 possible answers. 12 months. A little bit of splay. Some people thinking maybe 6 months may be appropriate. So let's talk about all these things. So we're going to start by emphasizing that the setting, the clinical setting in which a stent is placed has a lot of implications for how we treat that patient going forward. And stable ischemic heart disease is not the same as an acute coronary syndrome, is not the same as STEMI. These are very different animals clinically